Yes, Rajat, please go ahead.
Yeah, so good evening, everyone. At the onset, I'd like to thank the UC board members and the AIOS board members for this opportunity. So, I would like to discuss what's new in pediatric ophthalmology. Many would believe that pediatric specialty is probably the one which is the least, changing specialty, but it's not true. So, today's talk will be covering the following headings: amblyopia management, the latest in myopia, the latest imaging techniques which we are using for strabismus, new advances in pediatric cataracts, and surgical part of strabismus. So, with respect to amblyopia, as we all know, the general modalities for treatment are patching, and it can be using occlusion or pharmaceutical. So, some of the other modalities used are perioptics, cam simulator, as shown in the picture, vision stimulation exercises, pharmacotherapy, liquid shuttle, crystal shutter glasses, and iPad-based exercises. So, coming to the medical management, levodopa has been tried for the treatment of amblyopia. Many studies have been done on this. The basic mechanism is that it increases the age of plasticity. So even beyond the age of 8 to 10 years, which we consider the age of plasticity, we can still stretch and get some effect for the amblyopia therapy. However, many studies have pointed that it adds an adjunct to the routine occlusion therapy, but not independently, it cannot be used. Then for the refractory and residual cases where the challenge begins, we have tried combined optical and atropine penalization. So this is called as the code therapy. And an in-house study from our institute showed that there is definitely a better improvement with the combined therapy when we use atropine once a day, 2 times a week, along with patching whatever hours we have decided. So it definitely gives the adjunctive effect. Liquid crystal shutter glasses, also Amblyoz. This actually there's a shutter in the glass where it alternates between an open state and a closed state. It's better tolerated by kids and shown to have good results. But the newer modalities revolve around the dichoptic exercises. So because of poor compliance of kids with patching, atropine with its own side effects, so we have moved towards the dichoptic exercises. Here, as you can see on the image. The child is given the simulator, and on the normal eye, which is the left side, there's a low contrast objects have been shown, and on the amblyopic eye we give a high contrast objects. This leads to binocular summation of images, and gradually the contrast of the amblyopic eye also increased. Now, coming from the eye pad, which is like the eye patches, to the iPad, which we all know now, many therapies have been now coming on the iPad, especially some games, which also have shown good results. I'm not going into details of that. Coming to the myopia management, this is a real problem right now with the COVID pandemic, which we have. And so now we all know that there are both genetic and environmental factors which involve the development of myopia and progression of myopia, and associated with high near work. So with the more use of screen, this is now a real problem. And we have done there's a Cochrane review which showed various modalities of treatment of amblyopia, in which they showed that atropine has a maximum effect in slowing the progression. So the landmark studies done for this was the ATOM 1 and ATOM 2 trials. In the ATOM 1 study, there were 400 patients. They used 1% atropine eye drops versus the lubricant group. And this showed significant reduction in the progression of myopia in children less than 2 years. However, this was associated with a significant rebound phenomena after almost 2 to 3 years. This led to the ATOM 2 study, in which they compared the safety and efficacy of 0.5%, zero point 0.1, and 0.01%. And they came to a conclusion that the atropine minimal concentration, which is 0.01%, has a similar efficacy, whereas it has minimal side effects. So as of now, these are commercially available, and we are using it routinely. Coming to imaging, so high resolution CT and MRI imaging has made our life much simpler for complex strabismus. It has led us to find out the various mechanisms behind complex strabismus, like the one in myopic strabismus fixus. As you can see in this image, we can trace the muscle. This is a quasi-coronal cuts, in which we can see that the superior rectus is nasalized and lateral rectus is inferiorly displaced because of the elongation of eyeball posteriorly. And this led us to this group of Dr. Yokoyama to describe the technique of band loop myopexy for treating this. Similarly, other complex strabismus such as thyroid diseases and CFUM, we can find out the status of the extraocular muscles on the quasicoronal and axial cuts, axial and sagittal cuts, and we can plan surgeries better. Similarly, in trauma, high resolution CT, we can find where the exact fractures are. This is a newer sequence modality called as Fiesta sequence, which is fast imaging employing steady state acquisition. This is basically for tracing the cranial nerve pathways. As you can see, the image on the left is the Fiesta sequence, and the right is the normal sequence. And all the like this image shows the oculomotor nerve, this shows the trochlear nerve, and trigeminal and the abducens nerve. So as you can see, the even the branches of the trigeminal we can delineate. So for very small lesions of the optic nerve pathways, we can pick it up. And coming to dynamic or functional MRI, here we take the scans in the various position of gazes and gives us more information about the functional aspect of the muscle. With respect to pediatric cataract, the latest thing which we are trying is the Zepto technology. It's a precision pulse capsulotomy. Many are using it for adult cataracts as well. It is made up of a disposable single-use ninitol ring, which has a suction silicone cup. And this is just a basic step. So as you can see, foldable ring is inserted into the eye in a pediatric case, and it's then unfolded and suction is applied. And once you give the power, that is when there's a simultaneous dissection of the anterior lens capsule, and you can get a very round centered rhexis, especially important in cases such as pediatric lenticonus and all those things. There are many strabismus surgeries. None of them are new, but they are again come back in vogue. I will not go into details of all. Muscle transplantation, which was described very early, but now we have started using it for various new large angle strabismus and other complex strabismus. Here, these are just the images showing the steps of surgery. I'm not going to go into details of that. And the newer thing which we are still trying to learn is the minimally invasive strabismus surgery, or MIS. This is done with the use of microscope. Here, the conjunctival openings are made far away from the limbus, and keyhole small openings are made. And all the surgical steps are performed through small tunnels which are created. And almost all of the surgeries can be done using this technique, including recession, dissection, plication, etc. This technique is described by Dr. Daniel Mojon. Recently, he's popularized it. And this you can see is the difference between the incision with respect to the limbal fornix, and these are the MIS incisions. As you can see, very small pocket keyhole kind of incisions through which this surgical steps are performed. The advantages of this is it reduces the tissue trauma. There are lesser complications, better patient control. And to conclude my talk, I will just mention a brief about the use of fibrin glue. So we have stopped using almost any kind of sutures for closing conjunctiva, even squint cases. So we are using the fibrin glue, which is a biological tissue adhesive. Has two components, which when mixed, they act and they create a glue-like effect. And advantages of this being in squint surgery, that it reduces surgical time, and also it provides better patient comfort. I'll conclude my talk here, and